Thank you, Matt, and welcome everybody. We acknowledge this land that we meet on today as the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. And we also pay respects to the cultural authority of Aboriginal people attending from other areas of Australia. There are many stories in the data we've published, as you were told, and as mentioned in the notice that was sent out, I'm going to talk about three main areas with a few little bits at the end about a few other things that I think are important. They are the overweight and obesity and changes, mental ill health, and premature mortality. Suffice to say that the focus of this presentation is not on the many advances in the health of Australians over many years. As you can see there, this statement from the Institute of Health and Welfare points out that nearly 2 in 3 adults in Australia are considered overweight or obese. And the Australian Burden of Disease Study 2011 modelled the impact of overweight and obesity and showed it's one of the leading risk factors for ill health and death, such that 7% of the total health burden in Australia in 2011 was due to overweight and obesity, and that this burden increased with increasing level of socioeconomic disadvantage. So this graph was prepared and sent to me by the ABS when I was involved in doing the statistics for the first and only report of the Australian National Preventive Health Agency. And they produced it with data for 95 and 2011-12 to show the change that's occurred over time then and on again further. Particular note is this decline from the line for 1995 to 2022 in the proportion at a normal weight or a healthy weight. And it's somewhat of a decline here in this first part of overweight, but particularly also this area of obese into the three classes of obesity, 1, 2, and 3, the increase, which has offset these earlier. So this is a shift. And I have other graphs which put the intervening lines in for the intervening surveys that the ABS have actually measured height and weight to get the body mass index. And they just all fit within these outer bounds and show the gradual movement from time to time. If I go to a table of the data, you'll be able to see here, there's been an increase of over 2/3 in those living with obesity over the period from 1995 to 2022. And as you can see, it's not completely smooth. There was this increase in each of these periods and then a steadying off. At the same time as we had this increase, there's also been this decrease in normal weight from 41% to under a third. Again, some movement here particularly, and then down into this period and this stable, more stable. There's a lot to take in here, but the presentation of my notes will be available online for you to get to look at this later if you wish. That was for adults, and now for children. Sorry, before I get there, sorry. What struck me most too, I think, was the numbers. We're looking at the percentages, keep hearing percent, but back in 1995, of the nearly 13 million people who were in scope for the National Health Survey, the numbers weren't that different between normal weight and overweight. But by 2022, again measured data, there's almost a third in each of these classes, of 6,000 or so. So I think that's really struck me, the number of people that are in these groups. And these changes represent a major challenge for the health system in treating and caring for people with increased weight, whether women during pregnancy, and I mention this because there was a recent article in the media in the last week arguments for and against the increasing rate of elective caesareans, and the fact that there's me thinking, yes, it's over the top, but then the arguments put that with a number of women getting heavier and moving into the higher weight classes, sometimes it is very important to do an elective. So again, it's just the fact that there's quite a bit going on there, and other people seeking surgery, obviously it can cause complications. And this is aside from any impact on individuals with this disease. So again, it's a very important area with a lot of implications. For children, just aged 2 to 17, the proportion living with obesity rose quite strongly. From the 5.2 to the 8.3%. Overweight and obesity together, it's gone up a third. But the normal weight has gone down as well as for adults, but not as much. Note that the children living with obesity does not make up as high a proportion of the overweight and obese as for adults. But for children, it's a 30% of the total made up of obese, whereas for adults it was nearly half, 48%. Again, these are measured data that the ABS have collected. And in the December update of the Atlas, we'll be publishing prevalence estimates by our small areas, population health areas, and by local government areas and PHNs for the risk factors of overweight and obesity for adults and for children, as well as for adults waist measurement, and blood pressure, self-assessed health, psychological stress, smoking rates, physical inactivity, and alcohol use against the guidelines. These are based on modelled estimates by the Bureau of Statistics. Moving on to mental health area, the second area I want to mention, it's obviously been a concern for a very long time, but in recent years it has really become a heightened concern. Recently, in 2020 to 2022, the ABS conducted the National Study of Mental Health and Wellbeing, the first mental health specific or dedicated mental health survey since 2007. And the study revealed high prevalence of 12-month mental health disorders, and they reported them broadly as anxiety disorders, affective or mood disorders, and substance use disorders. I pulled out just a couple of statistics, and some of you, of course, may have seen this because the ABS have published this, that over 1 in 5 people in the 16 to 85-year age range had one of the 12-month disorders, or any of them. Almost 2 in 5 young people, 16 to 24, had one of these. And this is 38.8%, or over 1 million people, young people. And among young people, it was 40% higher among females than males. 66% higher for anxiety disorders, 61% for affective disorders, and half the level for substance use disorders. So this 1 million people in this young age group who had any of these mental health disorders, 600,000 females and 450,000 males. And in the next age group up, 25 to 34, similar proportions. Mouse is getting stuck on the tab. So that's just putting the proportions and into a chart form. I should have said before that we'll also be publishing those prevalence of those disorders by population health area and local government area in the December update for the Atlas. Again, modelled data from the ABS. And our September quarter release included, for the first time, data for services provided by community mental health care services around the nation and the number of individual patients. Next year, we hope to access some of these data on community mental health care patients disaggregated by age to see the impact on younger people and older people. We already publish emergency department data presentations, those people presenting for mental and behavioural disorders by age. whether in our maps or by quintile of disadvantage. So back to this slide, looking at the person 16 to 85, the whole cohort, looking at it by age and sex, the first bar of any 12-month disorder, then the anxiety, affective and substance use. You can see the drop-off, but the importance of these first two bars particularly right through, and the substance use relatively high mostly in the first age group. There are a number of ways that the ABS have cut these data. Here are the data for females and males in two age groups, showing the female to male ratio percentages for 16 to 24-year-olds and then for 25 to 34-year-olds. So once again, the totals in the first bar. You can see that the higher proportion of females to males in both these anxiety and affective disorders, but again, the substance use are much higher in males, so much lower for females. Although in this age group, it's a little bit higher than the earlier age group. And in this graph, we can see that here's the rate ratio of 1, which is the average for Australia, but of everybody that was in the survey, whereas you can see that those born in Australia have higher proportions for all of these conditions than those who weren't born in Australia, and particularly in the substance use one. And the ratio of females to males or women demanders that was reported in the study, again, you can see the total, but then particularly this anxiety disorders, including depression and other disorders, being very high. And other groups, other variations like the unemployed, seriously affected by some of these disorders overall, and particularly by the affective disorders, the mood disorders, and also reporting higher levels of substance use. It's interesting, these two groups of workers, the community and personal service workers and sales workers. I guess both of these are relatively low paid workers in relatively low paid jobs. And in this case, they compare with all employed. But there's also occupations with little job control, which is, as we know, is an important thing of people having some dignity in life and some feeling of what they're doing as being worthwhile. And the last one of these, I think, is this is the most to least disadvantaged, looking at the proportion who are in the most disadvantaged areas across Australia that were in the survey to the least disadvantaged areas, using the Australian Bureau of Statistics Index of Relative Socioeconomic Disadvantage, and see that the more disadvantaged areas are showing up in these areas of anxiety and affective disorders, but a little bit lower on the substance use. This chart, the next two bars, look at people who have never been without a place to live. And you can see again the impact, particularly in this area of affective disorders and substance use. So many issues that people who are working in the mental health area have to deal with. And the last one, which is about the number of people incarcerated, relatively small numbers there, but because there are 750,000 people with a 12-month disorder who've ever been without a permanent place to live. That's 18% of the total without a 12-month mental disorder. So quite a high proportion. Housing, stable housing is obviously a key, as we know. It's a no-brainer, but again, it comes through in these data. And this chart looks at the number of people who've self-harmed for males in the darker bar and for females in the lighter bar. And it's young people, quite a high proportions of them have, relative to the whole survey, have self-harmed. And what I think is of really great concern is that women from midlife, obviously facing many pressures, whether for interpersonal violence or low incomes, lack of housing and so on, again, they come up as in extremely high proportions. Again, an area of concern, no doubt, for many people dealing with and working with people with and providing services for people with mental health and mental health concerns. Sorry. What do that data say about change over time? There have been substantial increases over many years in the reporting of mental health conditions in national health surveys run by the ABS and the state-based reporting systems based on self-reported data. In fact, the national health surveys between 2004-05 and 2022 went up with the mental health disorder prevalence going up by 2.5 times. So it's difficult to determine the extent to which the increase is due to an increase in the propensity to report as mental health issues became more widely spoken about, or to an increase in the prevalence of these conditions. However, the ABS adjusted the 2007 data in a minor way to make it comparable with the 2022 data, and that was another dedicated mental health survey in 2007, clinically comparable. And they show an increase over this 15-year period from 19.5% to 21.5% in the age group 16 to 85 years of people with any 12-month mental disorder. And what they reported was quite surprised me at first, but that all of the increase of this 2 percentage points came from the 16 to 24-year age group. This change is largely driven by rates and prevalence among females. And here we can see those figures that the proportion among females has gone up from 30% to 40%. That's a total increase of 53%. The increase for males is from 23 to 32, an increase of 39%. So it's a particular problem for everybody, particularly for young people and some older people, and for young people, it's particularly so for females. And this one by socioeconomic disadvantage, comparing the 2007 survey and the 2022 survey, shows that there's been a change around in the rate ratios, that rather an unusual change in that usually the gap grows wider, but in this case, because the proportion has grown this bar more so than at the disadvantaged end, the rate ratio has dropped from a gap between here and here of 34% to 11% gap now. So something that, again, was a bit unusual. So there's a lot to unpack, including the impact of government funding of early intervention and youth mental services from around 2005, which is an extremely important initiative, but maybe implemented with a limited focus on prevention, from what I can see or gather. It's hoped to be hoped that prevention is to the front and centre of any new strategy in this area, which is being talked about by government. And the third area is about premature mortality. And anyone that's been to any of these presentations over the last few years will say, oh, here it goes again. But there are a few changes here. It's not all just the same. But this first graph shows both overall mortality, all ages mortality, and it shows the premature death rate as well. And you can see a slight decline in this. It's certainly coming down for overall death rate until in this position here, which is that's 2019 and that's 2021. It was back to about the same after a bit of COVID. But then the increase to 2022 is a result of an increase of 20,000 deaths, the ABS report, almost half of which were due to COVID. So that's in the all ages. Whereas when we do the 0 to 74, we get a much smaller increase because of the death rate, mainly for COVID, was over in that older age group, I think 4/5. But looking just at premature mortality, it's clear that the decline has slowed, if not flattened out, aside from the increase in 19 and 22 we've spoken about. So there's been this major decline of overall still 51% decline in premature mortality, which is a good outcome, reflecting many initiatives throughout government campaigns, legislation in areas about seatbelts, smoking cessation, physical activity, screening initiatives, SunSmart, better diets that have been taken up by many in the community and resulted in fewer premature deaths. But this table gets back to the point that many of you have seen from us in the past. You can see in the interactive graphs we've got on the PHIDU website, comparing deaths over time, premature mortality, deaths before age 75 over time. So a selection of years, I've just pulled out a few because the list was too long to put on the slide. And it shows them by this quintile of socioeconomic disadvantage, where the geographical areas in Australia, for which we have the death data, are ranked by the socioeconomic status of their population. We use the IRSD to this index of relative socioeconomic disadvantage, and we're all ranked. We then cut those into 5 groups based on equal population, and then re-aggregate the groups and calculate the death rates. So then we get a death rate for 1987 in this least disadvantaged areas of 347.9 thousand per 100,000 population, as against 500.9 in the most disadvantaged. That's around this average of 426. So there's the average has come down by 51%, which I mentioned before. Note that the quintiles are arranged as social sciences do them, rather with the least disadvantaged first, rather than the way economists do it with most disadvantaged in the left-hand column. So a couple of things here. What's happened here is there's a gap of 44% between this figure and this figure back in 87. Over time, the gap has increased to be more than double in recent years. So while the rates are down by 51% overall, that's because we've got a 60% reduction in this least disadvantaged areas and 42.7 in the most. So that's widened the gap. What's also of concern is it took till 2000 before the most disadvantaged areas, people in those areas had the death rate was the same as in the least disadvantaged areas 13 years earlier. In some states, it was longer than that, a few more earlier, of course. So with this as a 3-year moving average to smooth out a few bumps in the series, although there aren't that many. And you can see that it has flattened. We don't know, not really sure about the reason for this increase. Talk about globalisation, rates of exchange, all sorts of things are talked about, but nobody's really put a finger on it. I certainly haven't heard anyone. Nor for the flattening out in this period. So it is good that it's flattened out, but it's still at double. I'm not sure what we're going to see in the coming years. Of course, by concentrating on the ends of the spectrum, we ignore the fact that it's worse for every step along the way. This social gradient across the socioeconomic spectrum, with an increase in premature mortality rates at every step. between the least and the most disadvantaged areas. Of course, we can do it by 10 groups or 20 groups, the same effect. You can repeat this for capital cities, for Sydney, balance of New South Wales, Brisbane, balance of Queensland, similar result. This social gradient, of course, is prevalent across many data sets, and you can see it in the monitoring inequality graphs on the PHIDU website. And the mortality data cannot be viewed without an acknowledgement of the much higher burden borne by Aboriginal and Torres Strait Islander people. Although these social gradients look pretty similar, they are a bit stronger for the Indigenous population than the non-Indigenous. And we also know that this end of the spectrum, particularly in the non-Indigenous, there'll be some misreporting of, and which may even lower the rates for the non-Indigenous. But you can see that the rates have come down in these cases from the late 1990s to the latest period we've got data for, 1996 here. They've come down. We've sorted them by different measures of disadvantage. This is a socioeconomic outcomes measure that developed at Centre for Aboriginal Economic Policy Research at ANU we use. And this is the ABS Index of Relative Socioeconomic Disadvantage. They look pretty similar, but of course, then you look at the axes, and this is 800, and this is 200, 4 times the size of the rate in the Aboriginal to the non-Indigenous. It shows you the definition and the substantially higher rates of mortality, premature mortality among First Nations people. And lastly, from our latest release, with 1/5, 20.4% of deaths from COVID over this period, 2018 to 22, being below 75 years, we weren't able to map the data, but we were able to produce these graphs, which shows what we knew, that there were higher rates among more disadvantaged groups. We're surprised at the extent to which remoteness was coming here, which no doubt this is largely driven by the deaths of Aboriginal people, and a lot of work was done and people in Aboriginal communities were locking themselves off and looking after themselves, but the rates do increase very quickly from major cities, dropping off through inter-regional, outer-regional, remote, the Australian Bureau of Statistics remoteness area classification, but there's much higher rate, again, relative to the others in the very remote areas. But again, you know, the numbers are relatively small, but the rate is quite high. A couple of things I wanted to mention, which I think lead into my final comments. Something that surprised us a few censuses back, and we went back and checked with the ABS that all the data were correct. No, that's coming up in there. This one, the people left school at age 10 or below, or did not go to school. This is looking at 2006 to 2021. The education authorities changed it from a question asking people who left school before age 15, which made a lot of sense, especially for people coming from overseas to Australia. Now supposed to know what year 10 is. But anyway, you can see that there's been a drop in the proportion of those people coming in this way. But there's a rate, very hard to see probably, that there's an increase in the ratio from 84% higher to over 2 times, but the rate between this end of the spectrum and this end. So again, it's about the equity gap, as we can call it, growing, although rates in every quintile are down, but still got this growth in the equity gap. So I just put down some correlations that you can get from our double map atlas for any capital city or regional area or state. Rates of people who left school early at year 10 or didn't go to school, and some selected variables. And you can see there's some pretty strong correlations here. Adelaide is very socially segregated as to where our social housing used to be. So very high correlations, even in Sydney though, with its large populations, some pretty high. You can see differences between the poor results from bowel screening, for instance, highly correlated with disadvantage with people who left school early but they're also participating lower in inverse correlations. So there's quite a lot to look at in the double map atlas or correlation atlas. And then you have to have a map somewhere. This is to remind us of the power of the map and the entrenched nature of socioeconomic disadvantage. This is from 1986 and 2021, converted as best we could given boundary changes. So the first one is left school at age 15 or earlier, and then this one is for the second map, left school at year 10 or earlier. And you can see as the city centre is here, and outer northern and western suburbs here, you can see very similar patterns, and these are highly correlated data. And you can see we've produced the maps for a few other cities, so Greater Sydney, Greater Melbourne, Greater Brisbane and Greater Adelaide, for a few variables. So early school leavers, children in low-income welfare dependent families, the index of relative socioeconomic disadvantage, premature mortality, and admissions to public hospital. And that link is on here, but it's also going to be available further down. This is the one I meant to say. We went back to the ABS to check about two censuses ago, because we couldn't believe that the proportions of children and families where the mother has low educational achievement was going down, because it hadn't been. And this seems a great achievement. It must make a big difference to those children and their education and their chances in life. You can see the percentages have gone down quite strongly from 30% down to 14%. Unfortunately, the gap has widened, which is part of what we see, but it is good to see an overall improvement. Not sure whether that's by policy, by chance. Final words. Despite what the blank slide suggests, I am going to say some final words. This has been the hardest part to get my head around, as many people attending have considerable expertise in this field I'm talking about, and also there's so much to say, but I'm not sure I've nailed it, but here's what I'm going to say. Firstly, there's no denying that in any international comparison, Australia is a healthy country, that we as Australians enjoy relatively good health and wellbeing. However, the equity gap in many indicator sets is of concern and often growing. What do we see that governments in Australia have done and are doing? So, of course, it's of importance to good health is we have a strong, supportive social framework, and we generally do. We've got Medicare, NDIS, the welfare system, despite some glaring deficiencies about the level for job seeker. Notable recent improvements to the basic wage for some of the lowest pay. But in some of the areas, things are worsening. We certainly need a fairer taxation system that covers not just income but wealth, where the biggest divide now exists. We need universally available and accessible education. Although in Australia it's very much a tiered system with vastly unequal government funding, or as a former director of the OECD put it earlier this week, we need to rethink an education system that is focused on elitism. But in the health sector, we've always had attempts and work towards improving prevention. And it certainly needs to go on a lot further, and it requires much more than just increasing access to primary health care. We hear a lot about evidence-based policy. It seems to me there is a lot of evidence. It can be better, can be clearer, but I wonder if we let it down somewhere with policy that is effective, such as cutting the smoking rates or in seat belts, lots of things over the time. Policy, though, that's not only in health, but it's well coordinated right across government. And it's not just discarded at each election cycle. But the policy, of course, needs to be supported in the community by the professions. We need that support to ward off the influence of big business, of sporting identities and politicians when their interests are threatened. Just one example being betting advertisements. The conclusion: in recent years, there's been increasing discussion and action in some jurisdictions about universal childcare and universal preschool for children before they start school, both of which can contribute to reducing inequality and are important areas for action. We've known this for decades. We're still talking, reviewing and developing policy. Just one last example. In 2006, in his formal budget reply, the then opposition leader, Beazley, pledged $200 million towards building 260 new childcare centres on primary school grounds and community land. It didn't happen, of course, because party politics intervened. And only now is there talk about action in this area. So there is room for optimism. But while most of us are not too negatively affected, the urgency to address the equity issues may be somewhat lacking. So thank you, and I'd just like to firstly acknowledge the long-term support of the Commonwealth through the Department of Health and its other names, Health and Aged Care Now, as Matt mentioned, long-term funding. The efforts of those who collect the data on which we rely and hope we add value to by presenting the atlas, and the PHIDU staff for their role. If you have any questions or comments, please unmute and go ahead. And there's a link at the bottom here, which is, once you're on our website, you'll find publications and all publications. And by the middle of the week, we'll have some presentation up that Daniel's been recording and a copy of the PowerPoint and notes. So please, if there's any questions or comments, I'll be happy to. I can see Matt's got a hand there.
I thought I'd take the opportunity to go first, John. Thank you, firstly, for the amazing presentation. The data are incredible, depressing, but incredible. And I was reflecting on one of the comments you made, particularly around the need for prevention, earlier intervention being at the root of many of these issues, and combining that with how interrelated all of these particular issues are, and what could be achieved by reflecting on the interrelation. And I was following one train of thought around obesity in children from some of the first data that you presented, and thinking about obesity rates in children which lead to poorer health outcomes. And one example that you can link obesity through, for example, then leads to the potential for earlier puberty, which then leads to the potential for poorer mental health, psychosocial outcomes, etc., which then closes the circle to lead back to more propensity for obesity and more mental health, etc. And you consider that that's from an outcome in a range of ages that are sort of 10, 11, 12-year-old kids. The notion of prevention is actually, I think, in many cases far earlier than where some of these interventions are currently placed, and shifting that view all the way through to early intervention, I think, is really important. That's my personal soapbox, but that's just an observation. Thank you, John.
Yeah, thanks, Matt. Yeah, look, it's been, work's been done in this area for decades about the early intervention. It is now, as I say, coming through perhaps in preschool, for universal preschool and so on. But again, it's also supporting parents and making choices, and parents having the resources and the time to make those choices. But yeah, these things are all cycles. And I suppose that the last time Australia had anything that I'm aware of was anything like they've done in Britain over the years, and in terms of a major report on, was the 1988 Better Health for All, where somebody tried to look across the whole system at which we should intervene and we should work. And I was wondering, it's now 36 years on, and maybe we should be trying to think of coming up with a broad picture and a narrative, as people like to say, about where we go, because we're all working away in our areas and various people try it, but a whole of government overall thing is I think lacking. And that would look at, many groups are looking at young children and trying to intervene more early, but it's a matter of bringing things to the fore that we need to be doing alongside that. I don't know if there's any more questions. If there are, if anyone's unmuted, just go ahead. Otherwise, we'll Okay, well, as I said, the presentation and recording and so on will be up on the PHIDU website by the middle of next week. And so thank you for your attendance, and appreciate that. Goodbye.
Thank you very much, John. Thank you, everyone.